Welcome to Retina Health for Life from the President's Corner, brought to you by the American Society of Retina Specialists. I'm your host, Dr. Tim Murray, coming to you from Miami. On each episode, we'll bring you inspiring conversations about your sight and the special role the retina plays in making healthy vision possible. We'll hear from expert retina specialists as well as directly from patients about living life to the fullest with retinal disease. Join us and learn how to safeguard your retina health for life. Welcome to ASRS's Retina Health for Life from the President's Corner. On this episode, we're going to talk about intravitreal injections, also known as eye injections, a vital treatment option that retina specialists use to help save and improve our patients' sight. I'm very happy today to welcome my friend, colleague, and fellow retina specialist, Dr. Geoffrey Emerson, of the University of Minnesota at the Phillips Eye Institute to speak with us today. Welcome, Jeff.
Very glad to be here. Thanks, Tim.
So Jeff, you and I really know that these intravitreal injections have revolutionized how we're able to take care of our patients with neovascular or wet macular degeneration and diabetic retinopathy with diabetic macular edema, and even patients that have had strokes within the eyes. So I think that the issue for my patients is that it sounds terrifying at times to think that you're going to get an injection into your eye. Could you talk us through the process at your practice and how you administer an eye injection?
Yeah, eye injections, or more technically speaking, intravitreal injections, are really a very precise way to put medication into the eye next to the retina where it can treat retinal disease. And it's really a very small amount of medicine, but the eyeball is actually a special tight compartment where the medication can last for weeks. So this is really a very efficient way to target treatment exactly to the retina. And so there are lots of different types of medications that we can use during an intravitreal injection. The most common is anti-VEGF. VEGF stands for vascular endothelial growth factor. And that's a protein in solution. It's a complex protein that has a very strict target. So when we put that into the eye, it does a very specific thing. Now, to your question, when a patient comes into our clinic for an injection, it's kind of a process they go through. They start by having an exam and usually some testing, because we want to make sure that the treatment's working or that the treatment is the right thing to do for that particular patient.
So Jeff, when you look at that, one of the things we've been talking about is how do we image our patients? So in some ways, I think you're really focusing on the fact that how we look at the patient's eye before the injection may be just as important as how we give the injection. So how do your patients get imaged before injections in your office?
Yeah, so we check their vision to make sure that they're seeing what we expect them to see. And then they often go to get an OCT test, optical coherence tomography test, which is imaging that looks at the layers in the back of the eye in the retina so that we can see if they're responding to the treatment.
And then so you've gotten the patient image, they've had their eye pressure checked and their vision checked. Some of us, for each visit, actually dilate our patients' eyes to look at the eyes. Some of my colleagues don't do that. But once you're to the point to giving the injection, can you take us through how that happens?
Yeah, so the patient's sitting in a chair, much like an exam chair. We make sure they're comfortable. We numb the eyes, so of course they're comfortable, and clean the eye in a special way. Infections are very serious, so we don't want that. We hold them pretty still with an eyelid protector and have them look in the opposite direction. And then the eye injection itself is very quick. It's only 1 or 2 seconds. I think the worst part about these eye injections is that the eye feels scratchy later that day. It feels like a piece of sand or something inside the eye.
So what do you do with your patients after injection therapy to deal with that kind of surface discomfort that they have?
Most patients go home and take it easy for the rest of the day. They could take some Tylenol or ibuprofen. Also, artificial tears are very helpful for rinsing off the surface of the eye, and just the lubrication can help with the healing process.
How do you explain to the patient for their first injection? Because I find that's the one my patients are most anxious about. I think once my patients have had their first injection, they're kind of like, is that it? And they're surprised in a way at how easy that was to do. So do you have a team that gets your patients prepped, or do you do that yourself? How does that happen in your office?
Well, I'm usually in the room with the patient for most of the time we're getting ready, but some staff is helping me get the injection ready and get the cleaning supplies ready. And then if I step out, they talk the patient through the process some more. So I do think it helps to hear from multiple people how it's going to go, so then they don't feel like there's any surprise happening. I agree with you that the fear of something coming is probably worse than the actual 1 or 2 seconds of the injection.
And the other thing, Jeff, I know we talk about sort of these best practices, and there's no standard single approach to an injection. But for our patients, we use that lid speculum to stabilize the eye and pull the eyelids away. I find my patients really don't like that part of the procedure, but I've still felt pretty strict about doing that because the infection rates for us in the practice have actually been so low. So one of the things is interesting to me is that we all do this kind of a little bit differently. And for patients that just see you all the time or me all the time, it's easy. But when patients share injections with different retina specialists, sometimes they're surprised how different they are. Do you use a lid speculum to hold the lid open, and how do your patients feel about that?
I do, and my patients feel a lot like your patients. That's some of the discomfort. And we try not to dilly-dally. We try to get the job done once the lid speculum is in, so we can take it out, and then the normal blink can return. Because that's a little bit funny to be trying to blink and not able to blink.
I think that's true. And then interestingly for us, there are multiple anti-VEGF agents that we use, and they're personalized to the patient and their condition, but they're all really relatively the same injection experience. Unlike something like steroids, where patients are injected with triamcinolone acetonide, because of the tumor practice that I have, we use a fair amount of intravitreal steroids. Do you do that also?
I do. And like you say, that's a different set of symptoms because they get this flurry of floaters for a day or two, which you get to a much lesser degree with the anti-VEGF.
Yeah, we've had a couple of our patients literally feel like they have lost all the vision in the eye as the injection goes in. Um, and that's a little terrifying. So we do spend a little bit more time even with our intravitreal steroid patients to remind them and to tell them how different this may be. We also inject other things in the eyes for infections, from antibiotics to antivirals, sometimes even antifungals. But I think that for most of us, the two classes of drugs, the anti-VEGFs and the steroids, are the ones we use most commonly. When you're looking at your patients, I know the Minnesotans are a tough group, but have you had patients that were refusing to have injections within your office because of how fearful they were? And if so, how did you manage that?
I think there are some patients that are really scared, and unfortunately, that type of patient tends to disappear, and they don't come to their appointment because they're scared.
Right.
So I think if I'm sensing that a patient's really scared, I sometimes delay the treatment until the next time just so we can talk and build more of a relationship between the two of us, a little more trust. I think that helps a lot. Um, like you said, even for the most scared patient, it often turns out that they have their injection and they say, just like you said, that was it. Um, and when they have a good experience like that, they're much more willing to come back the next time.
I've also found that, we have patients as they're waiting to go into the injection room that have the opportunity to talk to each other. And I think that's very helpful from one patient's perspective to another. Sometimes they have a focus that you and I may miss a little bit in discussing what concerns us. The other thing that's been interesting is that almost never do we use any systemic medications to lower anxiety for the patients. But I've had maybe 3 patients in the last 10 years that really needed that to help them. And when we do that, we ask their medical doctor to get involved so that they can prescribe and monitor for that. Have you had to use any type of anti-anxiety meds for your patients?
Very rarely, less than 1%.
So I think that one of the things that's important to us is really to demystify these injections so that so that our patients in particular and their family members understand better what we're doing and aren't so concerned. And I think that we do so many of these that it makes this not routine in our office, but certainly something that moves rapidly. So do you have any pearls for your patients beyond what we've discussed in terms of what questions do they ask that we haven't touched on?
Well, I think, part of the fear comes from, is it going to hurt? And we've touched on that already. Um, some other fears that are really on the top of their mind are, am I going to lose my vision from the disease? And I've been amazed by by patients who I'm bringing back monthly, and I might say something like, "Boy, I bet you're getting tired of seeing me," and they almost always say, "No, I am really glad to be here because the alternative is terrible," and and it really helps to remember that these medications work. 90% of the time, they stop losing vision. Half of those patients actually improve. And this has such a positive effect on the patient's life that that fear of pain during the injection uh, decreases.
Yeah, so I have that same experience where I think the patients are initially apprehensive, but when they see the benefit, they're very willing to continue their injections. So to me, having practiced before there were anti-VEGF or targeted steroid injections, patients with wet macular degeneration and bad diabetic macular edema, they went blind and there was so little that we could do. So I'm like you, I spend a big part of this educating them to the advantages of the injection therapy. And I think that makes a big difference when they can understand. And it also makes a big difference with the pandemic. Several of our patients have not been able to come back as they have been scheduled. And they're very focused at getting into the office as quickly as they can for the concern of losing vision. And patients that have been delayed from returning to have their injections often can lose vision. So the injection itself is part of this, but the imaging that we do before to know how to inject and then the scheduling after, I think are as critical. The other thing that patients ask routinely for me, Jeff, and maybe for you also is, am I going to need these injections for the rest of my life? And what do you say to that?
Well, the short answer is yes, because this is a treatment and not a cure. I mean, we wish we had a cure, but um, it's actually a little more complicated than that because Early in the disease, they typically need frequent injections, maybe every month. But as the disease, as the macular degeneration gets under better control, then maybe we can space out the visits to every 2 months or every 3 months or every 4 months. And so it becomes less of a burden.
Yeah, so I think that I say that also. I give my patients the example of diabetes, where you're controlling this disease with daily treatments. But if you don't stay on target with the treatments, there's the potential that you can have a major crisis. And I think also the understanding that for most of our patients, we can extend the interval and personalize the treatment to how they're doing based on the imaging. I think that's important. But at the beginning, I think I focus really on the fact that the key is to have enough injections given often enough to control the disease.
One thing that I find kind of fun is when the patients are coming back in and they often see their OCT before I see it. And they start to learn how to interpret those images, and they have a sense that their vision's better. But when they can see it on the OCT screen, that's very exciting to the patient.
Yeah, I found that's been huge. So we put the last image from the last visit on top, and just below it, the same comparable image from this visit. And I'm like you, my patients, after a couple of visits, they have read their OCTs. They know they're better. They know they need to be injected. They're fairly focused on sort of owning their own care as they go through this. I'm always amazed by that. I think that's that opportunity also to see and visualize what we're seeing allows them to better understand why these treatments are as important as they are. So Jeff, what do you see for treatment options as we go forward? What do we do for patients that do not respond to an anti-VEGF, or patients that may have other issues like bleeding that's significant? Do you discuss other treatment options for your patients?
Yes, for the vast majority, the injection is the number one best treatment, but there are other treatments. There are lasers and there is surgery. So, for example, if a patient has a big bleed, you need more than just medication. You have to do surgery and basically vacuum out the blood to help the healing process. But the same applies. Those are not cures either. And there are complications and consequences to doing the more invasive procedures compared to an intravitreal injection.
Yeah, so I think that of all the treatments that we have for these patients, intravitreal injections are key. We lived through a time when we did a fair amount of surgery on these patients, but found that the intravitreal injections may be as effective, if not more effective. And then what I found is in the patients that I have operated on, they have still needed to be injected. So some of my patients are like, let's go to the operating room so I don't have to ever have an injection. And what I tell them is, if it were only that easy, but in fact, what we see is that we go to the operating room and we still have to inject. So I think that that helps you to have a good discussion with your patients. And it's interesting for us, Jeff, I don't think we see as many of those big hemorrhages as we saw before. And I think that's because we're treating earlier with anti-VEGF and we're controlling the disease activity before the patient goes on to have a significant hemorrhage. Would you agree with that?
Well, yeah, I think when a treatment has fewer complications, you can reach the threshold for treatment earlier. And when it's an invasive treatment, maybe you drag your feet longer and then get into trouble and there's a big bleed.
So I think what we've hoped to convey to our patients is that these injections, though they seem scary, are really not difficult for the patient or for us to perform. But there are some significant side effects for this. Could you take us through what you think the three major side effects to intravitreal injections may be?
There's some common side effects. We already mentioned the irritation that you feel after the shot, but also sometimes you can get a bleed on the side of the eye, on the white part of the eye, and that looks very red. It can look alarming even though it's not serious. Um, but the serious complications we worry about are infection, inflammation, and retinal detachment. Thankfully, those are quite rare. But it's important to have contact information like an emergency phone number and a good understanding between the patient and the clinic so they know exactly who to call when on that second or third day they're not feeling better or maybe getting worse. They definitely need to call and get some help.
Yeah, so we have a low threshold with the patients of having them call us if there's a concern. Fortunately, I think that the major complications that we worry about are incredibly small complications. So I usually tell our patients that our infection rate is about 1 per 15,000 injections in our office. And I think most people have a range between 1 in 3,000 and 1 in 20,000. So I tell my patients you're more likely to be in a car accident driving home than you are to get an infection, but like lightning striking somewhere, it could happen, and we want you to be aware of that because if it does happen, we want you in the office as quickly as possible. The other thing, Jeff, that's kind of interesting is that we've gotten some advantages recently about using a reservoir that's surgically implanted that can let drug go on and on and on, maybe for months and even maybe years. Have you had any thoughts on that?
Yeah, that's exciting. The possibility of having medication that lasts longer or a reservoir that can hold the medicine and release it slowly over time, uh, that's going to be great. Now, putting a reservoir into the eye is probably a more complicated procedure than putting a small injection into the eye. So we'll have to sort through those details. I also think that when we start thinking about longer term treatments like cures, how are we going to get the new treatment into the eye? It may end up being some variation of the intravitreal injection. Uh, I feel like intravitreal injection has been such a positive in our field that now we have this very high bar set with the intravitreal injection, and all new treatments are going to be compared to that, and they will also have a high bar.
Yeah, I think things are so effective at this point with the medications that we inject that it makes it difficult for a new medication to come online. And it seems to me that for some of these newer therapies, we're really not looking to do better with closing the blood vessels that are abnormal. We're looking for more sustained maintenance of that closure so the patient has a lower treatment related burden of care. So they don't have to come see us as much. They don't have to be injected as often. I will tell you, I must get several times a day. Why can't we give eye drops to treat these diseases? Why do we have to inject? Or why don't we use oral medications or systemic IV medications? Do you have any thoughts on that?
Yeah, I think it would be nice to have something simple like an eye drop or a oral medication instead of intravitreal injection, but those have challenges too. For example, with the eye drops, if it's a complex protein that's the medication, it may not get into the eye with a simple eye drop. You may have to literally put it inside the eye. Or with systemic medication like a pill or an intravenous medication, remember that medicine's going everywhere in the body. And if it's a powerful drug or powerful medication, it could have some serious side effects elsewhere. Uh, with regard to the anti-VEGFs, that some of those side effects are serious, like heart attack and stroke, and we don't want that. We want our powerful medication going directly to the part of the body that we're treating.
Yeah, I think that's really a good comment. So we've tried some of the drop therapies and they really have not yet been effective. And we have used some of the systemic treatments, but they've also been associated with more complications outside of the eye and much more complications overall. One of the things too that I do, Jeff, when I talk to these patients, to my patients, is I make sure to ask them to tell their medical doctor. But often they think that we're giving a systemic anti-VEGF and they're worried about systemic complications. We have to tell them that, the volume is 100 microliters, like 2 drops from an eye drop bottle. That's how I put it. And that we're really amazed that those medications have no significant effects beyond the eye. So that's, I think, reassuring for our patients and their, comprehensive physician or specialist. The other thing that you touched on are some of these newer advances. And I think one of the things all our patients are interested in is the concept of gene therapy. And you've mentioned that gene therapy likely could end up being delivered by an intravitreal injection. Currently, the gene therapies available for pediatric retinal dystrophies require a surgical approach. But I think you and I are hoping that that won't be the way we have to deliver. Do you think that we're seeing the potential for a deliverable gene therapy in the short term, 2 to 3 years, or do you think we're looking at a little longer time horizon?
I think it's coming. It's coming soon for some diseases and probably later for other diseases. And I can think of 2 different broad categories for this. One way you can do gene therapy is to target a gene and repair the gene. Another way to do gene therapy is to encode a medication and put it into the eye so you're up producing a specific medication that's going to help the disease. I think we're much closer to the latter, and it's going to be a while before we get to a cure for macular degeneration because there are so many different genes involved.
But I think the comment you made is really interesting. So I like that description of actually having the eye essentially become its own factory to make the medication for us so that we don't have to keep injecting the patient. Their own eye is going to make the anti-VEGF for us. I think that's incredibly exciting for our patients and, may revolutionize care for us as we go forward. So Jeff, I'd like to thank you, Dr. Emerson, for joining us. I think that you've done a superb job educating our patients and their families about what to expect for intravitreal injections. And I'm really hopeful that our patients may be a little less anxious by better understanding what we do. So I would like to remind our patients that they can go to visit us on YouTube, that we also have asrs.org for patients, which is our website for patient information, and that they can follow us on Facebook and Twitter. So Dr. Emerson from Minnesota, thank you so much for joining us tonight.
Thank you.